Okay, hello everyone. Welcome to Being Patient Brain Talks. I'm Deborah Kahn, founder of Being Patient. Well, you all probably know we often tackle the problem of lack of diversity in research to get better outcomes with Alzheimer's disease research. So today we thought we would focus on some of the solutions out there. I mean, we all know there is a problem getting more people of color into research to really understand, in some cases, why certain groups are more predisposed to dementia. So joining us today, I'm really happy to have with us Dr. Charles Windon. Dr. Windon joins us from the Memory and Aging Center at UCSF in San Francisco. His clinic really focuses on outreach to underserved communities. He's especially focused on the African American community in the San Francisco Bay Area. So thanks very much, Dr. Windon, for joining us. Next is Dr. Joy Balls-Berry. What a great name. Dr. Balls-Berry is the Associate Professor of Neurology at Washington University School of Medicine. She's a core leader for the newly established Health Disparities and Equity Core in the Knight ADRC. She's one of the founders of Minority Women in Research Network, and she's very much focused on promoting community patient engagement in research conducted by minority women scientists interested in research collaborations, academic scholarships, innovation, and dissemination. And joining us is Dr. Jordan Lewis. He is Associate Director of the Memory Keepers Medical Discovery Team and a full professor with the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School Duluth campus. Dr. Lewis has really focused on the Alaska Native community and serving in various capacities related to health disparities and elder health. Now, it took me a long time to read because you guys all have so many credentials, but thank you so much for joining us. We're very excited that you're with us today to talk about the research landscape and what are some of the solutions out there to create more health equity in Alzheimer's research. So let's just start first with, really we know there's a need for more research populations from populations of color. But first, I really want to focus on from a clinical aspect. Sorry, my phone was on. How exactly is this holding research back? What is it that we would be able to understand if we have more health equity? I'll throw that out to, I think any of you could answer that question.
So I think you said, what are we leaving out by not having diversity?
How have we not been able to advance given the lack of diversity in research?
We can look at, clinical trial data, especially with drug development and things like that. A really good case study would be when Aduhelm came out a few months ago, and how the diversity in that trial, it was over 3,000 participants, and only about 20 of the participants, 19 or 20, were people of color. Now, not only was that a disparity that happened with Aduhelm, there was also the fact that when the drug came to market, the cost of the drug was also a issue at 50-something thousand. And then the drug company Biogen reduced the cost to a little over 20,000, like 26K. But that didn't take into consideration all of the things that have to be done when a patient is prescribed that particular drug. You have to go to an infusion center, which means transportation. You also have to have a care person or a support person with you when you take the medicine, which means someone else also has to have time. And then there were multiple MRIs and other things that would also happen through that care scenario. So in thinking about participants that come from very diverse backgrounds or those that come from lower socioeconomic strata, are they going to, one, be able to afford the medication? Is it going to be covered through insurance or Medicaid or Medicare? And then what does that look like? And then where was the misstep in terms of thinking about the diversity of the participants that were enrolled in the trial? And, so that was a big issue. And new drugs that are coming to market that are somewhat promising in the same space, some of those have tried to diversify, but some of those populations have not necessarily been US-based populations. So, so we also have to consider that as well. And I'm not a physician, so,
right. Yeah, no, absolutely. And I think those are very important points. Dr. Windon, you're involved in clinical research at UCSF. Give us a perspective from the clinician's point of view.
Sure. So a couple of thoughts. So I think when we think about the purpose of research, when we think about the purpose of research for the, purposes of drug development, inherent within clinical research and clinical trials is the assumption that whatever therapy that is being developed is actually going to be applicable to the target population, to the population in which it's being introduced. And so when we talk about diversity in the context of research and in the context of clinical trials, it's important, I think, to also define what are we talking about specifically with regards to diversity, right? So many of us focus obviously on ethnocultural diversity, but we understand there is no biological basis to race. There's no biological basis to race. What there is, however, is that there is different exposure to the different social determinants of health that is largely based on your ethnocultural identity as well as additional factors. So for example, if you are African American and live in the United States, you may have greater exposure to things like structural racism, the historical, essentially, practices of redlining, other things, all these social determinants of health that can actually impact your risk of disease, and not only your risk of disease, but actually the disease course in and of itself. And so I think when we think about what are we lacking when we don't have diversity in clinical trials, well, we're creating a medication that is basically tested in a group of individuals who don't reflect oftentimes the diverse lived experience of individuals in the United States. And so I would argue that our knowledge about the natural course of the disease itself is sometimes not comprehensive because we don't have people from all different walks of life. And the therapies that are being developed, again, may not be actually the most efficacious because you're not including this very wide collection of individuals that would inform the different therapies. And so from a clinician standpoint, if I'm sitting across the table from an individual in my office and they're asking about the newest therapy that has been developed for Alzheimer's, a disease-modifying therapy, one of the discussions that we truly have to have is, well, who was actually in the research trial that provided the data for this medication to be approved? Was this, or were the individuals who were in the research trial, were they like actually me as a patient? Did they have things like high blood pressure, diabetes? Did they have other conditions as well that may have, an impact on the actual impact of the efficacy of the therapy itself? So it becomes more difficult as a clinician to really talk about translation into clinical benefit when you actually get to the level of dealing with individual patients one-on-one.
And we talked, as Dr. Ballsbury mentioned, about really the health equity issues that exists within the system. But Dr. Lewis, what I really want to understand too is some of the cultural resistance to research participation. Now, you've focused on Alaskan Native populations, which you've studied and really kind of integrated into that community. Can you tell us really what are some of the cultural barriers that exist within the Alaskan Native populations to research participation?
Yeah, so that's a great question. I think so. And I think it goes across a variety of different groups, like this mistrust of healthcare, whether it's past unethical research that's happened in our communities, bad experiences with healthcare providers. We hear a lot of stories of, in Alaska, for example, you may never see the same healthcare provider twice, whether it's because they come up because they want to experience Alaska or they're there for a variety of different reasons. And people get tired of telling their same story over and over. The other experiences we've had is one could be health literacy issues. Really, how do we translate these research, talk about clinical trials in a way that's understandable? We're working with communities now looking at, well, clinical research is beneficial to the community and figuring out how do you frame that in a way where people see the benefit beyond just the clinical aspect. So for example, we're learning from our communities that positioning that research in a way that participating in clinical research will benefit the next generation. Your participation will improve the quality of life for somebody else. So taking it from off of them, like this is for you only, but helping other people as well. And it's the challenge of not seeing an instant benefit, or the promises have been broken. And so there's a lot of different variables that can contribute to this idea of fear. I would say, though, in Alaska, that the younger generations who may have a higher health literacy are more apt to join clinical research, and maybe using them as an avenue to talk to older adults or people who are experiencing cognitive impairment. Maybe another avenue, but
what about, I mean, I'm half Asian, and I know in Asian populations, it's really hard, especially with my older aunties. I remember when I launched Being Patient, they were a little bit horrified that I was telling the world that my mom had Alzheimer's disease. I didn't look at it as something you should hide or be ashamed of, but that's, I think, a very cultural, that's a cultural difference, right? Anything that goes wrong with the brain is not something people want to talk about, especially in diverse populations. So tell me a little bit about kind of what you're seeing out in the communities about that. Is that norm changing? I mean, you mentioned, Dr. Lewis, about the next generation. Is that true with what you're seeing, both Dr. Balsbury and Dr. Windon?
So we just, as part of my NIH grant, where we are looking to diversify clinical trial enrollment and enrollment into other research, just not trial design, but even observational studies, we're creating a research registry that we call Coequal, where we're trying to reach a large cross-section of potential people that have no cognitive symptoms for Alzheimer's disease or related dementia. And so we held listening sessions with a little over 300 people. Trust is still coming up as a factor. People were saying things like, in our community, we don't necessarily see this as an issue. We just look at it as normal aging. And then when we start doing education around Alzheimer's disease and different types of dementia, and we say, well, no, normal aging looks like this. This is not normal aging. The other thing that we're seeing is, and I even can say this anecdotally, as a caregiver, my mom has had a lot of health challenges, especially in the past few months. Where she had brain surgery in 2007 and a bunch of other things going on with her cognitive health. She doesn't like to talk about some of those things. And I've said to her, I said, well, if you don't talk about it, then how do we do more prevention about it? And so I've asked permission from her on the things that I can share. Now, versus my dad, who passed from cancer it'll be 7 years in October, he was a scientist. So for him, talking about his health, being one of 12 or 13 people with a certain presentation from a rare presentation for bladder cancer, he was like, tell the world. He told his physicians who were on faculty at WashU, he's like, even if I pass, you need to write this up as a case study, because most of the cases were not in African Americans. But there is still that of, I don't want to appear weak.
Yeah.
I don't want to share these things because of trust, because of fatalism, because of will this impede me from having the resources I need in order to live, if people know. I mean, there's a variety of factors, and I found this across diseases, not just Alzheimer's disease. And so I think that for, especially in my community as a Black person, I'll say, oh yeah, we're studying this. I've been told not to share certain things around how I advocate as a caregiver, not just my life as a scientist. Oh girl, you shouldn't talk about that. But why? So we have to be able to provide safe spaces for people to share their stories, and then also honor when there is apprehension, and then help them find the words to share them in a way that they don't have more harm.
Yeah, I think that you're hitting a lot of really important points there. Dr. Windon, you are doing, I know Memory and Aging at UCSF is doing a lot of community outreach and community programs to tell us a little bit about how you're approaching really gaining trust of people of color.
Sure. So speaking a little bit about the outreach efforts that we've been doing, I'll speak about the outreach efforts we've been doing to the African American community in particular, which I spearhead. So how do we actually go about building relationships? How do we actually go about gaining trust? So I can give you a little bit of history. We historically didn't actually have significant outreach to the African American community prior to myself joining in training and then actually becoming a faculty member. And so I kind of helped build it from the ground up. And so I've seen it through the different iterations. But we were very intentional under my leadership in terms of approaching the community with a no ask policy, meaning we went to community leaders, we went to individuals in the community, and we had no specific ask for research participants. We had no specific ask for people to come to our center. We literally came with an offer. We wanted to just provide education. We asked folks in the community, hey, can we just have conversations with you about brain health? If we organize a couple of, activities, some brain health bingo with a brain health lecture afterwards, would you be willing to show up? And that's actually how we operated to begin. We did that for over a year, where all we were trying to do was get in front of folks, have conversations, and just allow them to get to know us, really. As that relationship developed and as people started to basically open up and trust us, then I believe people are naturally curious. The questions started to come in about, well, what does it mean to actually get a memory checkup? I read something about research at UCSF about brain health. What are you all actually doing in this research kind of space? So naturally, a lot of those things started to actually just creep into the natural course of conversations that we were having. But again, the approach was very, very intentional. The approach being a no ask approach on our behalf. And really, we sought to try to establish this bi-directional relationship where we were offering up services. Folks felt like they could openly communicate with us, and there wasn't necessarily this fear of an ulterior motive that we were going to follow the precedent that had been set before, which has already been alluded to. Very much the precedent from major institutions in the community is a researcher comes in because they want research participants or something else. The second the grant funding is over, that researcher is then gone, and the community never actually hears about the results of the research or sees the researcher again. So we really tried to combat that and have been, I think, effective in doing so.
So do you think it's much more effective to focus on health as that first conversation rather than disease, of course? I mean, it's, is it the same for the Alaskan Native population, Dr. Lewis? Is it focusing on health? And also within Native populations, we've spoken to other people who are advocates within that. They say the buy-in of the elder is extremely important to even penetrate the population. So can you tell us a little bit about your experience within the Native community?
Yeah, so in our work, so for my career, up until moving here for almost 4 years ago, has been really focused on how do Alaska Natives understand healthy aging and really having a more holistic approach to just what does the aging process look like, focusing from a strength-based perspective. Over the years, we've established those strong partnerships, and through conversations, whether it's just visiting, part of our work is just being in the community without the research perspective, right? We just want to be seen, go to basketball games, go to the grocery stores. They open up, right? And they're like, well, we hear about dementia, we hear about cancer, we hear about environmental toxins, and they want to know more. And so following those leads, we kind of begin asking more questions like, what do you want to know about that topic? Or let's look at what Alzheimer's could be in this community. And so, as you had mentioned, all of our work that we do, we have elder advisory councils on every project, every grant we have, and they kind of help us guide, like, what are the appropriate questions? Who are the people we should have at the table? And that having that buy-in is definitely really important. And they let us know, like, well, they're shifting now towards, well, elders are important, but we need to also include youth at this table. We need to have people who are younger because they're the people who are going to lead this community forward. And so that's kind of how we got to where we are.
Sorry, I don't mean to interrupt, but can you give us an example of what are some of the appropriate questions? Because I think actually that's what kind of gets to the heart of the issue as well. So give us some examples of what is appropriate and what's deemed inappropriate in that kind of initial stage.
So an appropriate question, and this is just based on the community we've worked in, and it may be different in different communities, but is really focusing from, I would say, again, that strength-based perspective, like, okay, well, this is your concern. If you're worried about memory issues, can you share more about what that is? And really having either the Elder Advisory Committee or the Tribal Council kind of work with us to figure out, how do we ask that in an appropriate way? Maybe it's, we just want to know more, like, what is brain health? What is Alzheimer's? As was mentioned earlier, most older adults in Alaska, it's a natural part of the aging process. So it's not really a concern. So how do we ask those questions of, like, what do you think Alzheimer's means to you? Or where did you learn about this? And what do you think it means? And how would you translate that into maybe education or training? And so again, this idea of bringing the youth to the table is really interesting because they have a much more biomedical perspective, whether they went to college, they have higher health literacy, they may be CNAs, went to med school or whatever. And so they are coming in with this, well, we need to learn more about the medications. There are caregiver support programs or these things that we could be accessing. And so blending those two together has been challenging, but it's also been enlightening to hear that the elders are more open to that. And that they're realizing that while there still may be cultural, spiritual views about dementia that we need to educate our providers on, they're open to these discussions and developing these questions.
Great, that's helpful. We have a question from Diana in the audience who is asking, isn't there a need to better understand ethnic differences in disease etiology and natural history? For example, vascular etiology versus amyloid, mixed pathologies, comorbid conditions. Are we, should we be looking, and I could add to that actually genetics as well, right? Are we looking through that lens in terms of, solving ethnic differences that pertain to research? Maybe you should answer that, Dr. Windon.
Sure. Yeah. So wonderful question. This is an area of really my interest in particular and some of my research in this area. So absolutely agree with the idea that we need to better understand ethnocultural differences in disease prevalence. So why, really? Why do we need to understand ethnocultural differences? It goes back again to therapies. How are we going to manage these things? So if we have a disease-modifying therapy for Alzheimer's disease, but the vast majority of individuals who have cognitive impairment, who identify, say, as Latino, African American, don't actually have Alzheimer's pathology within the brain, we would then be committing individuals to a therapy that is not going to be as effective as opposed to other therapies. And so there are many folks who are, because we now have the tools to be able to do this, there are many folks who are looking into what are ethnocultural differences in disease rates that we have kind of in the literature and in population, and really what are the actual causes of disease. So not all memory loss is Alzheimer's pathology, right? Not all cognitive impairment is something like Lewy body pathology. We have biomarkers that actually can now, while somebody's still alive, detect whether or not they have something like Alzheimer's pathology. And there are biomarkers coming for things like Lewy body pathology, Parkinson's disease, et cetera, et cetera. And so using these tools and having more inclusive research, we can really start to make headway in understanding what are the predominant causes of cognitive impairment among different ethnocultural groups, again, that are largely influenced by things like social determinants of health. If you live in an area where you have a food desert, meaning you don't have access to good nutrition, you don't have access to resources for physical activity, et cetera, you oftentimes are at higher risk for things like comorbid vascular conditions, hypertension, hyperlipidemia, diabetes. We know when you have these vascular conditions, it increases your risk of cerebrovascular disease as well. And cerebrovascular disease can cause cognitive impairment. So many researchers, including myself, suspect that a lot of the reason for cognitive impairment among underrepresented populations is actually more vascular in nature, and it's driven largely by these different social determinants of health. So really important question, and something that's really important to study is these ethnocultural differences.
But sorry, go ahead.
Yeah, I would agree, and in thinking about the risk factors for things like vascular dementia and thinking about, the social determinants of health, how do we move to a place of what we call precision health, right? Which takes into consideration the individual factors that might different risk factors for disease. It looks at the genetic components and other things like that. But it also, we also, as Dr. Windon mentioned, is studying those structural vulnerabilities that lead to health disparities, which then increase a person's risk factors for a variety of diseases. One of my biggest concerns when I started working in the aging and brain health space was the fact that I knew as an epidemiologist and a health educator that we probably needed to be doing more prevention early. And so some of the studies that have come out of WashU under the direction of John Morris and some of my colleagues have found that that many times the risk factors start 10 to 20 years prior to any symptoms. So if that is the case, and we're not only talking about Alzheimer's disease, but other types of dementia or cognitive impairment, then why hasn't the funding shifted in a way that will allow us to start thinking about prevention for those that are in their 20s and 30s before there is changes in vascular health, which then goes back to those observational studies in the community. Dr. Windon mentioned redlining. So in St. Louis, there's a lot of redlining. You go to deep North City, there's no hospitals, there's food deserts. There are, and then you go deep South City, it's the same thing. Deep North City is predominantly African-American and Black. And so, so you have to think about it in a variety of ways. And those ethnocultural factors are huge, but also the social political landscape related to racism and other forms of discrimination have impeded many communities from being able to have the access that they need in order to prevent things related to vascular disease.
Absolutely. I love that point. Sorry, I didn't mean to interrupt you, but just to say, our healthcare system doesn't focus on prevention. People wait for us to get sick and then they'll pay. So this is a point, and with brain health. So there's so, if you understand how biological systems relate, glucose metabolism, cholesterol, all of these things, those are good for your brain. But where are the resources to get tested and to teach people about prevention? That's not happening. And I'm glad that you brought up this point, because it's something I've learned on this journey, is there are ways to make your brain healthier. You have to really understand more about biology, and you need the resources to check what's going on, right? But if no one's going to pay for that, it's really hard. It's a big problem to solve. Sorry, Dr. Windon, did I cut you off? Were you
No. I just wanted to add just very briefly, because you asked also about kind of consideration of genetic factors. So we know genetic diversity is clinal across the human population, right? You don't have specific genetic code just because you're African American or Latino or Asian, so to speak. But again, it speaks to the importance of inclusion in terms of research, right? We want individuals from every different walk of life to capture that clinal diversity. But one thing that's really important, and Dr. Ball's various comments were right on point with this, is the idea of kind of prevention. And there's some very good research. There's a paper that was put out by Livingston some time ago that suggests 40% of dementia is actually modifiable. At least 40% of dementia is actually modifiable. So even if you have an increased genetic risk for dementia because you have a first-degree relative who had Alzheimer's, or et cetera, you can offset that significantly just simply by engaging in preventative measures.
And I think you're referring to the Lancet study. I'm going to ask my producer, Katie. We produced a guide based on that study, the modifiable risks to prevent. Katie, if you could post a link in the chat, that would be great, so that other people can access the guide. 12, I think it was, we called it 12 ways to prevent dementia, but it was the science-backed modifiable ways. So I want to end on really kind of stories of success. Okay, so I'm sure all three of you within your research and also community outreach have some stories to enlighten us with. Dr. Lewis, can you think of anything in particular where you really felt like, okay, this is making a difference? Give us a glimpse of what that looks like in the Alaskan Native population.
Sure. So in our successful aging work, and I guess going to this idea of prevention, right, and thinking about hopefully the work we're doing and getting all ages to think about what does healthy aging mean. In some of our communities we've worked with, we've learned that a lot of our communities haven't asked their elders, how have you aged well, or what have you done? We all kind of know, like, eat a healthy diet, stay active, and all these things that, you know, the general population knows is important for preventative health, but just good general health overall. But through our findings, we've had a few communities realize that, oh, well, this idea of bringing generations back together the way it used to be actually promotes health in a lot of different areas, not just physical health. And so we've seen a few communities actually use spaces in the community that have been unused or have been renovated to have very specific culturally based intergenerational programming. And it's been really exciting to see not only the benefits for the older adults who now may have a sense of purpose, their identity, they can speak their language or revive these cultural practices that have been, I wouldn't say lost, but maybe buried underneath because of, you know, whether it's boarding schools or missionaries or whatever has been happening in their community. And on the other end of that spectrum, you see these youth, again, like realizing they can have that pride in being Native, and they can learn their language, they can learn the history of their communities. And that aspect of there's more to health than just being physically active and having a healthy diet, but that sense of pride also contributes to a healthier well-being mentally and spiritually as well. So I think that hopefully that kind of work then will lead to better health practices over their lifespan and hopefully prevents health disparities later in life. But that would be the one that comes to mind.
I love that example. And what it reminds me of is outside Okinawa, they've put the old people's home in the center of town, and all activities run through that. So you have preschool there, you have everything. And what you were saying reminded me of that, right? It's the importance of socialization as well for brain health, and multi-generational. You are, creating opportunities for socialization and learning amongst generations. So I think that's a great example. Thank you so much for sharing that. Dr. Balsbury, do you have an example to share with us?
Yeah, so I'm from St. Louis, so I grew up here, and I also, after living away for about 19 years, when I moved back, having spent time at UCSF and other places as well, one of the big wins that I received was actually not necessarily related to Alzheimer's disease specifically. So when I moved back home, I wanted to reach out to community serving organizations like nonprofits and the like. And what I realized that many of the CEOs of these agencies were students of my mother, who taught high school here locally. And I'm named after her, or either they were colleagues of my dad's or friends of my older brother. And I'm like, well, how is this happening? And so it ended up being this very serendipitous thing where within the African-American community, we have play cousins and uncles and things like that. And so my dad's best friend passed from Alzheimer's complications. And when he passed, his family, and I have permission to share his story, donated his brain to the Night Alzheimer's Disease Research Center. He was a longtime study participant. His daughter is the is my community chair for my advisory board for my research lab, and all of these things. So there ended up being this bigger familiar connection for me in this disease space that I was unaware existed before I came home. Does that make sense?
Yeah.
And so as I, so like all of my big partners that serve on my advisory board have some connection to people I grew up with, which means to me that this is not only my quote unquote job for WashU, this is also part of my calling to be able to see some wins. And then when we did our what we call our brain aging cafes, our listening sessions within the community, each time we did one, a community member said, can you come to my church? Can you come to this community center? Can you come talk to our group? Can you provide education to this group? It started opening up doors for us to be able to provide more education about dementia overall, brain health overall, in a way that I know that we're making those that came before us proud. And so for me, that's a win. It means, we've talked to over 300 people, none of which have been approached to be in many of which, not all of them, but over probably 90% of them have not participated in any of our studies at WashU. Why? WashU's right here. And so, so that showed me that we needed to be doing more. And so I'm hoping that through these efforts that we'll be able to create an opportunity to prevent what Dr. Windon was describing of helicopter research, because everything that we're doing has to go back to the community, has to.
And what you're pointing out is how important it is for people like you to be out there leading that effort, someone who's trusted, someone who represents community. I think that's incredibly important. And, hats off to you for being where you are. I'm sure you're making a huge impact. Dr. Windon, do you have any stories to share within your clinical practice research with patients, anything?
Sure, yeah. So a lot of things that come to mind. I think the one thing that has been the most touching and the most impactful to see is actually to see community members become ambassadors for brain health themselves and actually pick up the torch and go and try to make a difference in the community with the knowledge that we've equipped them with around brain health. So I'll give you a specific example. We, at the end of last year, had a group of about 20 individuals come from neighborhoods around the San Francisco Bay Area. And we had them come actually for a day-long kind of symposium about brain health. So these were individuals that I had gotten to know over quite a bit of work in the community, over years of work essentially, but they came to our research center. We actually bussed them in, we provided meals, we provided a little bit of kind of swag giveaways for them to take home, but we really provided a comprehensive kind of education in Alzheimer's, dementia, and then actually the importance of giving back, the importance of contributing, specifically through things like research. So we actually all visited the brain bank together, and we actually went through some brain slides where we actually had individuals look at a real live brain that had been prepared for pathology. And after that day, I obviously have, relationships with each of these individuals and have kept in contact with them. But to see what has happened as a result, where they've gone back to their communities and they have actually started initiatives. They've started initiatives at their churches. They've started talking with local senior centers about the importance of brain health, activities to promote brain health. And even they've tried to make some headway in trying to get folks also more interested in brain health research. And so to know that by having just a small impact in the lives of some folks in the community, that they can then amplify really the importance of the message and feel like they're equipped with the tools they need to make a difference in their own community, that has been by far one of the most rewarding things, far above the fact that we've been able to increase the number of folks coming into our clinic from underrepresented populations. The fact we've actually been able to set up volunteer clinics in the communities where people need the most help and go and meet them where they are. all of the programming we've done, having them pick up the torch and really become ambassadors has held a special place in my heart.
That's great. A lot of this comes down to, really understanding education, and also just like reducing the stigma around the conversation, normalizing the conversation, right? So I think that's a great example. Thank you, all of you, Doctors Lewis, Ballsbury, and Windon, for sharing your expertise with us. This is a topic that needs a lot of attention. I think, really promoting what some of the solutions are out there is only going to help this. So thank you for sharing. We'll link to all of your bio pages and your research so that people can find you should they have any follow-up questions. But thanks to all of you for joining us.
Thank you for the opportunity.
For hosting.
Thank you.
And if you missed any of this interview, don't forget to go to beingpatient.com and sign up for our newsletter, because we post about all of these upcoming talks like this one. Thanks everyone for joining us, and we'll see you next time.